Ajaram. If any questions, please post in the chat box, all of you, or you may ask at the end. Either way, whichever is comfortable for you. Okay. Right. Let's move on. Good morning, students. I think we have to do this session 19 of our module. That is understanding of the abdominal science and approach to abdominal mass. So this is the topic for today. Let me just take you through this, and as we every time we do, today we are going to see and recollect all those important abdominal signs we discussed in the acute abdomen. And then I'm going to discuss on mass abdomen, that is how to approach a liver mass, enlarged spleen, and a right iliac fossa mass. So these are the three things, but of course, I'll be discussing other rare, less common lumps in the abdomen as far as the undergraduates are concerned. And if you are able to watch today, well and good. Otherwise, you can revisit the same by pressing SEM Surgery Masterclass number 19 module. Then you will get it in the YouTube, where you can watch few more times so that you can go confidently during your clinical examination. As I said, today I'm going to show you a lot of pictures so that you are able to visualize various signs, how to elicit, rather than trying to memorize them. And I'll be giving you some few important points so that you can keep them, take them as notes, so that you will think like me, think like a surgeon. So that's a very aim why we want to discuss with you. Okay, so with that, let's move on to the part one of our topic, that is approach to abdominal science. As an undergraduate, I would say probably these are the top 12 important abdominal signs one should be confidently able to discuss and describe as an undergraduate. During inspection and palpation for each, and during percussion, there are two signs worth remembering, and auscultation, at least these two, which I have mentioned in this list. We'll go one by one. As I said earlier, I'm sure you know them all, or most of them, if not. But still, it is worthwhile to know exactly the way an examiner likes. So let us listen to these signs and try to understand them without any confusion in your mind. Okay. What about this inspection sign? This is what I call, whenever you inspect the abdomen, you see the abdominal wall. And one of the important thing regarding is the position of the umbilicus. Very, very important. That we call as a Tanyol sign. That term Tanyol may not be commonly used. We always say the position of the umbilicus is it shifted upwards or downwards. That's what we say. If it is shifted upwards, for example, then it can happen in few conditions. Like for example, pelvic mass, because it is pushing from below upwards, the umbilicus understandably will be pushed up. Whereas in a patient with ascites or people with upper abdominal swelling, it is likelihood that umbilicus will be pushed down. But having said that, the position of the umbilicus is not accurate enough to come to a satisfactory any conclusion. But still it is worthwhile telling, compared to the normal position, the umbilicus appears to be shifted upwards and downwards. From this, we can infer in some conditions, especially in a pelvic mass, if it is pushed up, it implies that there is an ovarian cyst or a large uterine mass, so that pushing the umbilicus upwards. Okay. Next, this particular sign, I'm sure all of you know by this time, periumbilical ecchymosis, a sign of retroperitoneal bleed, like a ruptured ectopic, acute pancreatitis, leaking abdominal aortic aneurysm, or a splenic injury. These are the four important conditions which gives rise to this Cullen sign, not only Cullen sign, and also the Gray Turner sign. What is Gray Turner sign? Recollect, whenever they ask you any sign, first define the sign and tell what are the conditions you will see that particular sign. So Gray Turner sign is an ecchymosis in the loin. It is seen in four different conditions like Cullen sign, namely acute pancreatitis, ectopic pregnancy, splenic injury, leaking abdominal aortic aneurysm. These are the four things. So in other words, these two signs can be present in any of these 4 or 5 conditions. They are not pathognomic or specific to one particular condition. So they are not diagnostic of particular condition. That you should recollect. Okay. The next important thing I want you to recollect is whenever you see anything in the abdominal wall, like a small lump, you want to know the plane of the swelling. For that, you always do the head rise and leg rise. For that, we use this particular name, can be described by some, but you are not expected as an undergraduate to know that. But if you know, well and good, there is Garnett sign. A Garnett sign is a head raising or leg raising test. See, like that. You raise the leg so that abdominal musculature is put into contraction, or raise the head like this. So when you do that, if the swelling, especially the size of the mass, if it becomes less prominent, you know it is intra-abdominal, because of the abdominal wall musculature contracting, it makes the mass less prominent. Whereas if it is a parietal mass like a hernia or a small cyst in the abdominal wall or subcutaneous tissue mass, it will become more prominent. So that is what we normally do. But the Garnett sign actually means not the size of the mass, it is a tenderness or pain. They are only Garnett as described, just for you to just. So the Garnett sign we use loosely for size of the mass increasing or decreasing depending upon the head raising or leg raising. Whereas really this is used regarding the pain on head and leg raising. If you have increased pain on head raising, that is a abdominal wall or a parietal pain, whereas the pain is decreased on palpation on head raising, it is an intra-abdominal pain source. So that's where it is used, just for you, just to know the clarification. On palpation, there are at least 4 signs. All the 4 signs, thankfully, we discussed already. That is Murphy's sign, McBurney's sign, and a Rosing sign. What is Murphy's sign? Examiner will ask you. Then you will be very, very confident in telling the diagnosis or the description clearly in Viva in particular. Okay, you have to tell them, whenever you tell any sign, you have to tell what it is, how it is elicited. Anything else you know regarding the sign, you tell as a third one. Okay, don't go how to elicit straight away. That will confuse. So when they ask you, for example, what is Murphy's sign? Sir, Murphy's sign is a sign of acute cholecystitis. It is elicited by keeping the patient in a supine position. With my palm, I'll start palpating the abdomen below upwards. When I go in the subcostal region, just along the mid-clavicular line, when I ask the patient to take a deep inspiration, as the patient is taking a deep inspiration, the liver along with the gallbladder comes down because the diaphragm is coming down on inspiration because of the lung expansion. So the inflamed gallbladder will touch my finger. So patient will perceive the pain on the peak of inspiration or called zenith of inspiration. He says it hurts, sir. It hurts me there when I take a deep breath. Okay. So that is what a Murphy's sign. So Murphy's sign is a sign of acute cholecystitis where there is a tenderness on deep inspiration by placing your hand in the right costal margin along the mid-clavicular line. That is the way to tell. And Murphy's sign can be also elicited by using your left thumb, putting it in the same place like this. Okay, that is called Moynihan's modification of Murphy's sign. And today's homework for you all, if you already know well and good, is there is one more Murphy's sign. What is that another thing? That is the lunate dislocation. There is a Murphy's sign. So you find out, go and read what is the lunate dislocation, what Murphy described there. Okay. The next important thing is, of course, more common than Murphy is for you undergraduate is McBurney's sign. What is McBurney's sign? McBurney's sign is a sign of acute appendicitis. At the junction of the lateral 1/3 and medial 2/3 of an imaginary spino-umbilical line between the anterior superior iliac spine to the umbilicus, if you just put a hand or a finger, ideally, as for the McBurney, it is only a point of your finger, not the hand. Patient will perceive an acute tenderness. Then you say McBurney's sign present. So the tenderness or a point of tenderness at the junction of the lateral 1/3, medial 2/3 along the spino-umbilical line. That is a very sensitive, specific sign of acute appendicitis. But we discussed in the acute appendicitis chapter itself, appendix is a variable position, so it need not present in all cases McBurney's sign. So we need to have additional signs to confirm the possibility of the appendix being in different position, like pre-ileal, post-ileal, retrocecal, pelvic, subcecal, things like that, subhepatic, things like that. Okay. So Rosing sign is another equally sensitive sign, less commonly used, wherein if they ask you, Rosing sign, you tell, is another sign like McBurney sign to confirm the diagnosis of acute appendicitis, sir. In this sign, when I put my hand and feel the left iliac fossa, patient will perceive pain in the right iliac fossa. So pressure in the left iliac fossa, perception of the pain in the right iliac fossa by the patient. That is because of the shifted, the viscera in the abdomen causes tenderness because of the impingement on the inflamed parietal peritoneum over the inflamed appendix. Okay, so these are all the signs you have to elicit. There are humpty number of signs, but these are all the essential. And the next, the final one on palpation worth remembering for your life is, of course, the rebound tenderness, what we call a Blumberg sign, release sign, or a pointing tenderness. So wherein patient is in a supine position, you start feeling the abdomen gently, but start diverting the patient's attention as you palpate. When your patient is least expecting you, you just take your hand off the abdomen. When you take off the hand with the least, so the patient is least expecting that time, and it gives like a surprise suddenly because of the springing back of the inflamed parietal peritoneum. Patient perceives the pain. Patient face goes in for a wincing. He can experience, you can see the patient face, that will tell that he didn't enjoy the situation. That is when you take the hand without giving him any time, okay, to notice. So this is the thing. So very important for the examiner to tell. Blumberg sign is elicited nicely in such a way. You start gently palpating the abdomen, getting the reassurance of the patient. When the patient's attention is diverted by your constant communication, you suddenly release the hand when the patient is least expecting. And because of the sudden release, sudden springing back of the inflamed parietal peritoneal wall, patient will perceive the pain. That is this shifting, the rebound tenderness, that is rebound of the abdominal wall. And that is a very important sign of peritonitis. And that is a sign on which very many times as a surgeon, we base our clinical judgment, whether to operate on this patient or not. Radiologically, there are some signs like gas under the diaphragm, means perforated viscous, needs operation. Like that, a surgeon relies, most important sign he relies is, that is the tenderness, mainly the rebound tenderness. Okay, of course, board like rigidity. These are the two important things you have to decide. Next important sign, sometimes not common as an undergraduate will be able to have a time, but if you are posted in pediatric in particular, a 2-year-old, a 3-year-old child presenting with intermittent pain, vomiting, and they're coming to the emergency, you are able to examine if they are going, for example, ileocecal intersusception. So sign D dance is a sign of ileocecal intersusception. That is the first word you have to tell, wherein there will be empty right iliac fossa. So that is what you need to see. And there will be a sausage shaped mass around the umbilicus. It can be anywhere. See, for example, one particular patient they had a mass somewhere here. Okay, ileum going into the cecum. Then it moved here into the hepatic flexure. Then the ileum keep on going, telescoping of the bowel into the colon. So if it is very mobile right colon, then ileum will go into the transverse colon also. So it will keep on traversing the mass, and even it will come out of the anal canal as a prolapse mass. So red currant jelly, prolapsing mass in the rectum. In a child with a severe colicky pain, beware of an advanced case of ileocolic intersusception. Okay. Coming to the percussion signs. What are the percussion signs one will be interested to hear? One, of course, we already discussed in the splenic trauma is a balance sign. Another is a puddle sign. Okay. What is balance sign? Balance sign is a sign in a case of splenic trauma with a hemoperitoneum, sir. Like that you tell in the exam. How will you elicit that? Balance sign is a shifting dullness. So what you do is you percuss on both loins. Loin, right side and left side loin, you percuss. Then ask the patient to shift and percuss. The dullness in the right loin can be shifted, whereas the dullness in the left loin cannot be shifted. Why? Because the dullness in the right loin is shifted because of fluid blood will be shifted on you turning the patient. Whereas here it is a clotted blood here in the left loin, which will not be shifted. So in other words, shifting dullness in the right loin, not shifting dullness in the left loin. In a case of splenic trauma with a perisplenic hematoma and hemoperitoneum is called balance sign. That is the comprehensive, complete description of balance sign. Okay, like that, you repeatedly practice the description. That is the only way with a given vocabulary you will be able to express. Okay, the very important thing is a crisp, very clear message. Confidently, you have to discuss. That only will come with the practice. Okay, so you repeatedly you don't vomit what is written in the book. That's what I'm telling you. The book would have written something different from what I say, but I'm sure you understand what I'm trying to say here. So the same way you try to put your own words and describe, and that's the way. Because hardly there are about 12 signs I have described. There may be 10 more if you really want to be master of surgery. 25 signs, master them right and left, and discuss with your friends. It's like a chat, and whoever is doing the best way of description, okay, and they should be awarded and rewarded accordingly. Next, of course, is the curse sign. What is curse sign? Is a referred pain over the tip of the left shoulder in a case of splenic trauma. okay, because of a diaphragmatic irritation, because both share the same dermatome, diaphragm, and over the left shoulder is a T4. Okay, so that is what you need to describe. Coming to the next one, that is puddle sign. What is puddle sign? Puddle sign is a sign of a small amount of fluid in the peritoneal cavity. Can be illustrated if the patient is kept in a knee elbow position. So the puddle of water or a fluid inside will collect around the periumbilical region where you can percuss like this. Okay, so there is a periumbilical dullness or percussion when a patient is in a knee elbow position to describe or to discover the small amount of fluid in the peritoneal cavity. How much fluid we need? Around 200 ml, 100 to 200 ml you need for this. Shifting dullness about a liter. Fluid thrill 2 liters or more. Okay. So in other words, minimal fluid puddle sign, moderate amount of fluid shifting dullness, tense ascites, fluid thrill. So these are the three signs of fluid in the peritoneal cavity. Okay. Coming to the stethoscope. Now in the COVID pandemic, we don't use the stethoscope that often, but as an undergraduate, even if you're in the surgical thing, there are a lot of places where you will require auscultatory signs like a bruit, venous hum, or succussion flash, vowel sounds, things like that. So you need to have the auscultatory signs. The two signs worth recollecting here is one is a Creutzfeldt-Jakob sign. What is that? In a case of known chronic liver disease with a portal hypertension, who might have a periumbilical veins, predominantly in the epigastric region, because there is a flow of venous blood through the patent umbilical vein due to collaterals in the ligamentum teres, the falciform ligament, okay, ligamentum teres, there will be collaterals. So because of the constant hyperdynamic circulation, sometimes it will be only here or there will be something like a caput medusae, like a spokes of wheel across the all around the abdominal wall. Then if you put the diaphragm, you can hear the venous hum. That is Creutzfeldt-Jakob sign. But more commonly, we use this. This is the caput medusae. One more picture for you. And what is caput medusae? Because a surgeon might be very interested to know whether you know anything more. I told you, you describe the sign and also tell one or two words. What is caput medusae? It is a medusa head. It is a snake hair is turned into like a snake head. Okay, so this particular Greek mythology, you just have one or two words. Okay, sight of this Medusa head or the vision, and every soldier can become a stone, isn't it? So that is what it is. One of the important mythology. You may have to read few lines in order to impress the exam if you really want to. Succussion flash. What is succussion flash? Very important sign those days. Nowadays, we don't get this fairly advanced gastric outlet obstruction or intestinal obstruction. Here, ensure the patient had no food or a fluid in the last 3 hours. Otherwise, even you and me, if you have a 2 liters of water and a drink, and then you lie down, you will have a succussion flash. So that is a very important rule. Number one is ensure the patient is a empty stomach for 3 hours. Even then, in a gastric outlet obstruction, he'll have some remnant of fluid and food, isn't it? Then place a stethoscope in the epigastrium, shake the patient sideways. Then you can hear this to and fro noise of the air and fluid. You should have not only fluid, but air and fluid in a hollow viscous. So it is a sign of air and fluid moving to and fro in a hollow viscous. It can be in the small intestine or it can be in a stomach, commonly stomach in a gastric outlet obstruction. In a small intestine, in a case of intestinal obstruction. Okay, succussion flash. Right, now you are a complete surgeon now, like because you already know so many signs and your hands are itching to examine a patient. Now I'm going to bring hypothetically few patients on the floor here because with a virtual platform, it may not be like a ward round where you see a patient, you feel and all those things, but for the tactile feel, I'm sure you can examine. Now, normally when you train yourself, you try to have a normal patient without any mass. See how you examine the abdomen properly. Then you go for a case of splenomegaly and hepatomegaly, and if you're lucky day, right leg fossa mass or ovarian cyst, ascites, this, and of course an incisional hernia or umbilical hernia. If you have this, that's it. You pass your undergraduate. Very rarely we have a case given to you as undergraduate if it is available, like a pseudo pancreatic cyst or a right leg fossa mass of a various description, like ileocecal tuberculosis and things like that. Okay, so they are rare, but they can also come, or even a mucosal of gallbladder. All these things are very, very rare, but they can be kept if it is available. You never know. Okay. But if there is nothing is available, they can keep you small hernias also as an examination of the abdomen. But splenomegaly is the commonest, especially. Why it is common? Because chronic liver disease, patient coming every other month to my clinic. I have 10 splenomegaly cases every week we see. So we keep them for exam also. They all come, like they usually come during the examination time. So you remember, spleen is a very important organ to be examined by you. Whereas spleen, renal mass, or even for example, right leg fossa mass are less common during the examination time. So common things are common. So you should be very confident in examining an examination of the liver and spleen. Okay. Coming to the examination proper, let us understand the basics. I'm sure this is taking you to your third or fourth year in your undergraduate surgical curriculum, but still, I always think a good foundation is off the job done. 4 lines, 2 horizontal, 2 vertical lines divide our abdomen into 9 quadrants. You tell the quadrants. Sometimes the examiner will ask you, draw the quadrants by with your finger. So you need to draw. As you draw, you have to describe. 2 vertical lines are along the mid-clavicular line, mid-inguinal point, like this. 2 vertical lines I draw. 2 horizontal line. That is, one, of course, is the transpyloric, or what we call a subcostal line. Another is an intertubercular line. The intertubercular line is highest position between the 2 tubercles, okay, in the iliac crust, about 5 centimeter behind the anterior superior iliac spine. It is not between the iliac spine. Take it from me, okay? It is 5 centimeter at least from the anterior iliac spine. It will be intertubercular line and a transpyloric line. If you then you have this 9 quadrants. What is more important is not only knowing the quadrants by heart, by the name, but what is visualize the organ inside. That is what you should do. If I have a swelling in this region, in the epigastric region, what are the likelihood? Only if you know anatomically what are the normally they are present. Liver, stomach, aorta, bit of pancreas, lesser sac. These are all intra-abdominal. What about the abdominal wall also? Epigastric hernia. Isn't it? So like that you can carry on thinking about this. What about here in the right iliac fossa? Appendix, cecum, the terminal part of the mesentery, or a psoas muscle, iliopsoas abscess. So like that you have to, or iliac vessels. So like that you need to imagine. So what is going to be, in other words, you need to have a 3-dimensional anatomy of the abdomen as a whole. The abdomen, actually having a proper abdomen is only a small portion. A lot of abdomen is actually hidden in the rib cage, what we call a thoracic abdomen. Some of the abdominal organs are also hidden between the pelvis. There is a pelvic abdomen, isn't it? So pelvic abdomen, thoracic abdomen, and abdomen proper. But abdomen proper is what we are examining. It is only 1/3 of what you see, because the liver and spleen normally for you and me is not palpable. They are abdominal organs. When they are palpable, you think it is abnormal, some disease. So like that, you have to be like a bladder, normally not perceptible. But if the bladder, because of bladder neck obstruction, if it is distended, it becomes a hypogastric, a mass in the hypogastrium, dull on percussion, doesn't move with the respiration. It is bladder unless moved otherwise. You ask a patient to void and come, or you put a catheter and see, the mass will disappear. Okay, you do not have an ultrasound. So as simple as that. Like that, you should have a confidence and courage and common sense when you are trying to describe an examination. That only will come if you have the basics right and you have seen some patients in your clinic. So you keep on seeing liver and spleen, keep on palpating. 10 liver, 10 spleen have you palpated before going to your undergraduate examination. Then only you will have that amount of confidence to pass the exam. As simple as that. Okay. And in addition, most of the surgeons would have said to you, I am also telling, abdomen, it is not 9 quadrants. There is a 10th compartment, that is you have to examine the external genitalia. Groin, that is the hernial orifices, that is the 11th compartment. For rectal examination is also, you have to at least mention the examiner, I have to do a rectal examination. And number 13 is a left supraclavicular fossa or a trousseous sign. Okay, so these are all the important things you have to tell the examiner. Sir, I have examined the external genitalia, both groin, but I would like to see the rectal examination, and I have seen the left supraclavicular in the general examination itself. So like that, these are all the areas which are extension boxes of the abdominal cavity. Okay, that also you should know. Right. Imagine I am the patient. Okay, I'm having a pain in the abdomen. I have come with some mass. The examiner asks you, okay, that is your long case. Go on, spend some time, 15 minutes, take a history. Then examine. I'll join you. Then you go with a case sheet and you properly take a history. That is the challenge for all of you. How you are going to take a history. The very important thing is you get the patient's name, age, occupation, first line. The second thing, the prime symptom and the duration. Never forget that. Okay, these are the two things I repeatedly telling you. The name, okay, age, and then occupation. Now itself you get it right. Next is the prime symptom. There is a key symptoms in their own words and the duration. You get it and keep them written. Because those you tend to forget. In some examiner will like you to tell the patient name. There is no harm in telling because you and the examiner and patient is also there. There is nothing about a confidentiality. But when it comes to a virtual conference like here, or when you are examining in a big forum, then you say Mr. M, Mr. F, like that you can tell. But age is important, occupation is important because it is important in the treatment, diagnosis, various places, occupation may row. Like a TAO, I mean, the patient with the intermittent claudication, the occupation, if it is a lifestyle is modified, then you may have to operate on this patient. Like that, there are a lot of things, or some diseases because of the occupational hazards also. Like in medicine, you will see, okay, lots of things, occupational hazard, pulmonology, you will see. So symptoms and duration. The most important symptom as far as the abdomen is concerned, or anywhere in particular, is a pain. So get it right. Patient says, sir, I have a pain. The most important point as far as the pain is concerned is ask the patient to lift their dress, put the hand, their own hand, exactly where it hurts. Very, very important. They'll say pain in the abdomen. Pain in the abdomen is nothing to do because you need to exactly pinpoint whether the pain is in the epigastrium, periumbilical region, hypogastrium, or in the loin to groin, or it is a diffuse pain. If they say pains are everywhere, that is different. So this patient can have diffuse pain in the abdomen. There you describe. Otherwise, you tell this patient predominantly complaining of pain in the upper abdomen or epigastric region. Because the pain as far as abdomen is concerned, we have visited already. I'm repeating today. There are two pains. One is a visceral pain, parietal pain. Visceral pain, foregut, midgut, hindgut pain. What about the foregut pain? I told you, you already know. Epigastric pain, foregut, all the organs develop from foregut. Esophagus, stomach, up to the second part of duodenum, livers, and also pancreas, gallbladder. If you have any disease of these organs, they initially present with pain in vaguely in this region. Then depending upon, well, if it is a gallbladder, it will radiate to the right child. Okay, right side, the infrascapular region, or also sometime to the right shoulder. Okay, whereas if it is pancreas, it will go right through the back. That is additional thing, but basically the site is very important. Appendix from the midgut, so periumbilical pain. sigmoid colon, bladder from the hindgut, so hypogastric pain. Okay, character, very, very important, next important. But sight is 90% of the job is done. The character of the pain will give you, is a pain a continuous dull aching pain, or a coming and going, waxing and waning pain, like a colicky pain. Okay, there are various description, but you allow the patient to describe himself. Try to help him, but don't try to interpret. So he was telling, but he may be thinking, because very important thing normally we do in a hurry in exam because of the shortness of time. We ask them like a parent, you have pain? Yes or no? Like if you take yes or no monosyllabus, it should be all open-ended position. Okay, what is your problem? Pain. Where is the pain, you ask? Rather than, is a pain in epigastrium? You will say no or yes. That is not the question. So where is the pain? Like that, can you describe the pain a bit more better? Then you allow him to talk, because the initial few points not only allow the patient the freedom of expression, he'll get more confidence on you. Here is the doctor who is listening rather than asking. So listening is very important rather than asking in exam. That particular first 5 minutes of rapport, you can catch. It is like hare and what we call a tortoise. We say usually, even though we slow, when we slow and steady, we will be finished the examination well in time. There is no need to be in a hurry. The time given, it is only repeatedly you waste your time. Same inspection you do 2 times, rather than systematically. If you do once inspection, once palpation, once percussion, auscultate, finish. Don't keep on repeating. That is only comes with the practice. So be slow and steady. You will win the race or win the examination. Okay. The radiation is important, duration, and whether it is increasing as we go. The intensity is a crescendo nature, and aggravating relieving factor. Usually, pain related to acid peptic disease usually have some aggravating factor like a spicy food. Relieving factor by taking antacid. Okay, you can always tell. There is no point in asking only what is. You can tell, have you been given a prescription by a doctor or some of your friends, like an antacid, like Gelusil, commonly used antacid? Yes, sir, I had that, and that gives you 50% reduction or partly. So that means he has an upper abdominal pain, probably gastric or duodenal pathology. You can presume. So like that, you can associate symptoms also important. Okay, like pain usually will be associated with vomiting, and because of they don't feel like eating, so that they'll be anorexia, all those things. But because here it is a case of mass, you have to verify with the patient whether the patient himself or herself knows they have a mass. Sometimes the patient may not know they have a lump, but sometimes they come with a lump. Sir, I notice a pain, and as I felt a lump in the abdomen. Lump in the breast is very often patient comes with a lump, whereas abdominal lump or mass, patient may not show unless it is a parietal lump, but still is worthwhile asking. And anorexia, weight loss, very, very important sign. And these two are very important as far as the malignancy is concerned. Fever, especially in a case of inflammatory pathology, if you are going to diagnose, like ileocecal tuberculosis or appendicular mass, things like that. Okay. Then very simple. Once pain, mass, associate symptom described, you go for 3-department history. I simply say, what are the 3 departments? You imagine as if you're a gastroenterologist. What you will do as a gastroenterologist, because you are going to the GI department, they'll ask everything about the upper GI tract, like reflux, regurgitation of food, vomiting, or dyspepsia, things like that. Or lower GI tract, that is diarrhea, constipation, GI blood loss, either melena, a sign of upper GI blood loss, or fresh blood PR, there is a lower GI blood loss. Like that, you ask all the questions as a gastroenterologist perspective. That will finish. So any symptoms of GI origin, you keep in mind, ask those questions yourself. Then symptoms of hepatobiliopancreatic origin, HPP surgeon. Okay, liver means jaundice. Then urine, motion, color, pruritus, and things like that. Okay, and that's the way. Jaundice is very, very important because that will fix your lesion. Something wrong with the liver at the maximum, or spleen occasionally if it is a hemolytic anemia. Okay, and symptoms of urology specialist. Like urologist, how they'll ask you, especially like, so dysuria, hematuria, poor stream. Very, very important to get a habit. It may look very simple. You need to ask. Never satisfy with the monosyllabus also. If they say dysuria, what actually they mean? So burning micturition. So usually it is associated with frequency of urine. Is it day and night frequency, or is only at night? That is nocturia. If it is at night, how many times they have to get up at night? Because a 6-year-old man getting up at night once is okay. 70-year-old twice is okay. Whereas if it is more than that, or more than what they used to do 6 months before, that means they have some symptoms of prostatism. Okay, so frequency of urine, nocturia, and then failure to initiate voiding urine. That is a thing. Poor stream. So all these things are signs of prostatism. And hematuria, is it frank hematuria, painful hematuria, terminal hematuria, a sign of what is that, trigonitis or urethritis. That is when they squeeze the bladder. I like squeezing the toothpaste like that. The last end, when it comes, they bleed. Drops of blood at the end of the micturition, terminal hematuria. Very classical sign sometime in that trigonitis, or even a patient with urethritis also. Sometimes they can either way. They can have initial or later also. Past history. Of course, typical 3 or 4 things you almost, everybody will ask. I don't want to repeat that diabetes, hypertension, but what is important is any past history of abdominal surgery. Even if you forget here, when you examine the abdomen, you'll know, because the patient has a scar there. There is a signature by the surgeon, abdominal walls. Then you have to do that. In other words, examination of the abdominal mass, the history taking, doesn't mean only history taking, then go for examination. During examination, if you forget to ask history, you can go back always. Like if you see a scar, then ask, oh, I'm seeing a scar in the upper abdomen. Did you undergo a surgery? Yes, sir. Now the patient, 10 years ago. What for? How long you stayed in the hospital? What did the doctor tell you? So like that, you ask the patient all those things. Okay. So very, very important thing is the communication with the patient is throughout the examination. Don't keep it in the first 5 minutes, then allow the patient not to talk. You keep conversation with the patient, so he becomes friendly to you. Then sometimes even he recommends, sir, to the examiner, because examiner at the end, the patient will examine you at least in abroad. Okay, see, for example, if you go for MRCS or FRCS exams, what the examiner do is they keep you wait outside after your examination. They go back to the patient. How did the doctor do? The patient will say, sir, this particular candidate who sent to examine me is very, very kind to me. And he properly did all the examination, asked me and listened to me carefully. And he was very compassionate when I was having some pain, and he was just trying to console me. And he was listening to my, see, patient will give a perception how good you are. That actually makes an important mark in the examination system in abroad. It is not in our country, but still it is a good habit to develop the habit, because this is what all about in private practice. Patient makes an impression. That impression only comes how much attention you give, whatever patient says, or whatever you see in the patient's abdomen. Okay. Drug history, very, very important. Here all you need to write down, because sometimes your gray cells will forget. So recall when the examiner asks you to present your case, you have to tell them all what drug, what dosage, how long you've been, like diabetic drugs, hypertensive drugs, drugs like clopidogrel, aspirin, because these have implications in the management. Say, for example, a patient is taking aspirin, okay, and you are diagnosing that patient is having a incisional hernia, okay, abdomen. The examiner will ask you, okay, this patient, what do you do? Sir, this patient needs mesh repair for his incisional hernia, sir, that is a treatment. So when you do, then if you're a very clever student, you'll tell, sir, I'll admit the patient. I'll do all the pre-operative investigation. I'll ask the patient to stop taking the aspirin for 5 days before surgery after consultation with his physician or a cardiologist. Why you want to stop? Because stoppage of aspirin or clopidogrel is necessary to minimize the bleeding during surgery. Not only during surgery, even during anesthesia like a spinal or epidural anesthesia, sir. So both the anesthetist and surgeon would prefer the patient to have stopped taking drugs like aspirin, clopidogrel, or stop taking the warfarin. See, these are all the drug history, very, very important. And some patients, the drugs could be the reason for his problem, like a jaundice could be drug induced. So like that, drug history is important. Please take diet history is also important in a gastroenterology particular. Okay. Personal history, of course, smoking, alcohol. Don't say patient takes alcohol. That is not how long, how much, is it day and night, whether he asked to stop alcohol, whether he tried and failed, whether he has any findings suggestive of alcohol dependent syndrome. They'll ask you. When you call a patient alcohol dependent syndrome or alcoholic, you should be confidently in a position to tell that. Okay, smoking, how many, how long, what he smokes. Okay, all these things you have to tell. Then family history, especially some tumors like familial polyposis, like gastric cancers, all can run in family. So you better to ask a family history of similar diseases. And general examination and all these things. Very important thing is most of the things I told you already, hepatomegaly or a splenomegaly due to portal hypertension, because it's the commonest case we have in our wards. So liver failure signs, last class only we watched from head to foot, starting from jaundice, okay, or the parotid enlargement, anemia, and clubbing, spider neve, palmar erythema, Dupuytren's contracture, gynecomastia, all those liver failure signs you have to tell in addition to your normal things like cyanosis, clubbing, edema legs, all those things. Okay, so that's what I wanted to tell you. Let us go on to case by case. First, imagine now we are going to examination room. Patient is lying there, a good exposure in a privacy. You have to maintain a privacy. So a patient's side, there is a room available. So the patient is comfortable. He is not exposed to everybody. So, and also you just make sure all the 9 quadrants are exposed. The 10th quadrant you examine, then you cover it for a decency. Okay. Next, you inspect, palpate, percuss, auscultate, and write those findings. Okay. Hints alone, then you can tell in the exam. Inspection, 3 things you will see obviously. Abdominal wall, umbilicus, and any mass if it is something about the mass. Abdominal wall, here for example, the abdomen is slightly distended. All the quadrants moves equally with the respiration. There is no scar. There is no dilated veins. There is no obvious peristalsis seen, sir. The umbilicus is not easily visible, but imagine this is the umbilicus here. It appears normal in place position. Tanial sign is nothing. It is normal position. And is there any mass? There is no obvious mass. The abdomen is diffusely distended. That's all. But if there is a mass, then you go for a description of the mass. Okay, we'll come to that in a minute. But when you see a distended abdomen, they'll ask you. Sometimes they exam, okay, tell me few causes for distension of the abdomen. This is one of the mnemonics, often you know, but use it sensibly. That's what I'm telling you. For example, if you are having a lady patient, you can tell all these things. But if you have a male patient, tell me what are the possible causes for distension of the abdomen in this particular patient. If they ask, don't say 3rd trimester pregnancy. Okay, it may be all right because you remember that way all F's, but you don't make you fool of yourself by telling that. So always give the differential diagnosis relevant to the given patient. Very, very. If it is a child, accordingly. If it is a male adult, accordingly. If it is an elderly female, accordingly, use this. Hello, who is speaking? Please unmute yourself, Aparna. Okay, so for example, if it is a male adult, I will say this could be ascites, sir, or mesenteric cyst, or pseudopancreatic cyst, bowel obstruction, pneumoperitoneum. I'm not going to tell ovarian cyst or a 3rd trimester pregnancy here in a male. So like that, you have to be very, very, use your common sense. Okay, not only the knowledge you have. Let's go. The inspection, I told you, the Garnet test, the head raising and the leg raising. When you see, if it is like a parietal lump, like an umbilical hernia or a ventral hernia, they become more prominent. Whereas if you have a spleen, here is a left upper quadrant, that is, you see a mass, okay, in the left hypochondrium. So that is most equal, I mean, with respiration, which on head raising becomes less visible. So that is going to be an intra-abdominal mass. So more prominent, less prominent. If it is there, you just see. Again here, not only head, sometimes lower abdomen, leg raising might help you. So here, for example, epigastric hernia becomes more prominent on leg raising test, whereas if it is a big, here, of course, pelvic mass, it becomes less perceptible on head raising. Scars in the abdomen tell a lot of stories about what the patient's undergone in the future, because sometimes patient may recollect only one operation, but if you expose, there'll be 10 different scars. Then you have to ask the patient, what is this scar, this scar? I usually recommend the students, you draw a little diagram in your own case sheet and put the picture, and there you put the year of operation, because that's the way you remember. Because, sir, this patient is having a right subclass incision. 1964 he had a, or you can tell 36 years ago or 3 decades ago, he had a cholecystectomy, like that. So, yeah, operation. So you know the whole story about the patient by just looking at simple inspection. So you remember all these scars commonly used by the surgeon. The cockers are a right subcostal incision for open cholecystectomy. The paramedian incision, right or left paramedian, upper paramedian incision, done for any upper abdominal surgery like a vagotomy, GJ, perforation, things like that. A rooftop incision or a transverse incision in the upper abdomen, pancreatic surgery normally. A long midline incision, that is an incision done for all different abdominal conditions, commonly done for any acute emergency operations like intestinal obstruction, perforation. Then this is the McBurney's incision. This is the Lance incision. This is the Battle's incision, all in the right iliac fossa. They are the incisions made by different surgeons for the same operation, that is appendicectomy. So this is the McBurney's incision, where the skin incision and also the aponeurosis under the muscles, peritoneal incisions are crisscrossing with each other. Crisscrossing of all the layers of the abdominal wall ensures there is no weakness of the abdominal wall. That is what you should know. Okay, like that's why it is called this important. I mean, the McBurney's incision or the, whereas the Lance incision, okay, is a skin crease or cosmetically acceptable, whereas McBurney's is a gridiron. That's what the word I was looking for. Gridiron incision is a gridiron is like this. Okay, crisscrossing. Battle's incision is a pararectal. This is the rectus muscle, pararectal incision here. Okay, and muscle cutting incision on either side is called a Rutherford Morrison incision. Gynecologist, very often they put what we call a Fanon steel incision, which will be hidden under the dress, okay, for cesarean, hysterectomy, things like that. So in a lady with the Fanon steel, you can very well tell patient either had hysterectomy or a cesarean. You can always, even if the patient forgets, you can tell. Coming to the dilated veins also give you an idea what is the problem of obstruction and things like that. If you have a dilated veins, you have to tell patient has a dilated veins predominantly in the upper abdomen or in the lateral abdominal wall or all around the umbilicus. If there is, you test the flow. I told you, you just empty the vein, take one hand, then see. Empty the vein, take the other hand and see which way the flow is more. Normally, in the abdominal wall, the veins draining through the superficial epigastric vein to the great saphenous, that is through the inferior vena cava system. Whereas lateral thoracic vein, laterally up to the axillary vein, there is a superior vena cava territory. Okay, and when you have abnormal veins, you just remember this diagram. If you have a periumbilical vein, normally in a caput medusae, the flow is away from the umbilicus because the portal obstruction. So the flow is away from the portal vein. They want to join the systemic veins elsewhere to the superior vena cava, inferior vena cava territory. So spokes of the wheel like that, caput medusae. Whereas in a case of inferior vena cava obstruction, there is obstruction here in the inferior vena cava, the flow is along the lateral thoracoepigastric vein, the vein, it will be like this. Okay, in other words, superior, the flow is superior. Whereas if there is an obstruction here, then this vein will divert the blood to the inferior vena cava. So all the blood here cannot go this way. So they all come down, enter the inferior vena cava, then go up to the heart. So that is where you should infer. So superior vena cava infection, the flow of blood, direction of the flow is inferior, just opposite. Okay, remember that and demonstrate that to the examiner. This VGP, VIP also you should know. Sometimes if the patient is not able to, you can give a glass of water and just give a little tickle on the surface of the abdominal wall. Then you can see like a wave coming from left to right, okay, from the left side, from the splenic side to the liver side, like that it will come. That means gastric fundus, body, pylorus. That is the way the peristalsis moves. The dilated stomach with the peristalsis, we give you that visible gastric peristalsis. Whereas if you have intestinal thing like a chronic subacute obstruction of small bowel, then you have a step ladder pattern. So you see one wave appearing in the right iliac fossa, moving upward like this, or moving down like that. So you'll see a step ladder pattern. Okay. Now coming to the palpation. Before we go into the palpation, let me tell you the 6 principles of palpation. First, told you inspection itself, palpation, especially a women, ensure privacy. Make sure if you are a male, patient is a lady, ensure there is a lady nurse available. Very, very important, even in examination. Permission, implied consent. There are 2 types of consent. Written consent, implied or informed consent. You tell the patient or get a permission. Can I examine your tummy if you don't mind? At least it is a courtesy. Just go and don't poke. It will give up very awkward. So this is very important thing is that permission from the patient has to be obtained. Because in exam, they'll ask you, at least in abroad, have you asked the patient permission to examine? Because if the patient says to the examiner later, he just came and just examined without even asking me anything. Okay, he is very rude. Like that, they'll tell you. Very important thing is behave like a professional. Next is you always do like that. Then palpate with a warm hand, especially winter approaching. You should be very, very careful. And very important, next important thing, not many people will tell you, especially in our country, the cot is very low and you will be standing and you will be examining like this. Always you keep like what this examiner is doing. Keep the hand parallel to the abdomen. Even if it means you have to kneel on the side of the cot. See, very often in a pediatric ward, if you go and see the professors, they'll be kneeling on the side of the patient child and then talking to the patient child and then gently palpating like this. They have to palpate this way. You should not keep the hand and palpate. It should be parallel to the abdomen. Okay, if the abdomen is like that, you palpate like this. Don't palpate. Okay. Then always perform below upwards. That is from the right and left leg fossa, you just slowly go below upwards. You should be very gentle to feel. Then deeper palpation, double hand method, and a dipping method. What is dipping method? In ascites, you may have to do like that. One tap like that, like that. Because when you dip once, because the fluid is displaced, the mass will come and hit you like that spleen. Okay, so the dipping method it may be used in a case of patient with a fluid in the peritoneal cavity. Otherwise, you use either a gentle palpation to locate where the mass or where the tenderness. Then deeper palpation to know more about the mass. Then double hand method, especially to want to see the lower margin of the liver. Nicely you can feel. Okay. And the whole examination, don't look at the mass because mass is inside, it's not visible. Look at the patient face. I always examine like this. Okay, examine like that. You examine the patient face. If the patient face says, I am not enjoying your palpation, you stop it. Is it hurting you? You ask the patient and stop it. Don't keep on prodding because you may not be the one person. You may be the 10th doctor examining for that particular examination. And if you do the same thing, then if the patient makes a noise or makes big noise, and the examiner comes and finds out that the reason for the noise is patient didn't like the way you examine, then that itself is a works against you. So be very delicate. Treat the patient as a VIP. Then you describe the mass. How you describe the mass? See, there is a mass here. You can see. I can see there is a large mass in the left hypochondrium, extending onto the epigastrium and umbilical region. And on head raising and leg raising test, the mass becomes more prominent. That means it's a parietal. It is on feeling, you just feel it. It is not warm, it is not tender. On consistency, it is soft in consistency and ill-defined border. It is reducible and it is cough impulse is present. It is not pulsatile, doesn't move with the respiration. Okay, and there is no need, but still you can tell it is not bimanually palpable. But because you, as soon as you said it is a parietal mass, it is not necessary. Don't vomit everything, but as an undergraduate, you are not penalized, because whenever you see a mass, especially more to the hypochondrium, you are expected to tell this, but not in every case. So like that, you have to describe the mass to the fullest and systematically. After the most important thing, of course, is the site of the mass and size. Okay, let us take some hypothetical cases, like a liver, for example. What you are expected to tell about the liver. The liver, when you palpate, this is the way to palpate. You palpate the liver. At the end, you have to tell whether the liver is enlarged. Any palpable liver is enlarged liver in adult. In pediatrics, different. Consistency, okay, a firm or a hard in consistency. Firm in case of chronic hepatitis, chronic liver disease. Hard in consistency, usually in a secondary liver. Tenderness, present usually in a patient with the amoebic liver abscess, like inflamed pathology, or tenderness also in a hepatoma in malignancy also. Surface, nodular in a case of nodular cirrhotic liver, very often. Okay. Upper border and the lower border, very, very important. Very important thing is the upper border is palpable, lower border is palpable and upper border is percussible. That is what you should see. So how will you see? This is the way you describe. You start percussing from below upwards. From tympanic node, you can go on and you will feel an area of dullness. But this you already palpated the lower margin. So that is the lower border of the liver. Then you percuss from the above downwards in the intercostal space, from the resonance to the dullness. And you see the width. So this is the liver width, usually from 6 to 12 centimeters. Is variable along the mid-clavicular line, but you can always measure it by percussion node. So the upper border of the liver dullness is felt at the 4th or 5th intercostal space. That is normal. If it is 3rd or 2nd, that means it's grossly pushed. In other words, there is a shifting of the upper border. Normally 4th or 5th intercostal space. Okay. So that's about the liver. And what about the spleen? So spleen, I told you, is most important thing, because there is commonest lump kept and harmless lump, and even 10 people can examine, especially a patient with a portal hypertension or a chronic myeloid leukemia or a tropical splenomegaly cases. So you have to see the size. So always examine the spleen from where to where the examiner asks. I'll examine for spleen from the right iliac fossa. Why? Because when the spleen enlarges, it enlarges downwards towards the right iliac fossa. Whereas if it is a renal mass, it always descends down, if it is a left kidney, towards the left iliac fossa. Okay, so this is the one important. It crosses the midline. Spleen is the one thing, crosses the midline. Of course, liver is already crossing the midline because it has 2 lobes. How will you differentiate a spleen and also kidney? One of the important thing is kidney never crosses midline, unless rarely if it is a horseshoe kidney, of course. This spleen, it crosses the midline if it is a massive splenomegaly. Okay, that's why you start here. And if it is a small, very small spleen, how you feel? Feel with a deep palpation by pushing your hand in the lower chest wall like this. You bring it you just push it with your left hand forward, then ask the patient to take a deep inspiration, because the left dome of diaphragm brings the spleen down, and you just, it will touch the tip of your finger here. So the just perceptible small spleen can be palpated either by pushing my left hand on the back of the left lower chest. Ask the patient to take a deep inspiration, sir. Otherwise, I'll turn the patient to the right lateral position again, the same and again. So, patient in the supine and also in the right lateral position, ask the patient to take a deep inspiration, and the spleen which is hidden behind the 9th, 10th, 11th rib, it will come out and below the costal margin momentarily. That time you can feel it. And that is small spleen sometimes can be present in the thrombocytopenic purpura, hemolytic anemia. So it's be very careful. Okay. When you see a spleen, to say it is a spleen, one of the cardinal or two cardinal signs we say is, one, you are able to see it or feel a notch. Notch is a very important thing. Second, you are not able to, in other words, sorry, you are not able to insinuate your finger between the costal margin and the mass, because it is coming very close below the costal margin, so you will not be able to go like this. If it is a kidney, you may be able to do that. Okay. Let us see here the kidney now, for example. What about the kidney? How will you examine? Can you examine the right kidney, left kidney standing on the right side? Examiner asks you, yes, sir, you can do. Because you not go to the other side. Okay. Sometimes we go to the, for example, when you palpate the axillary lymph nodes, we sometimes go to the other side to examine the axillary lymph nodes other side. But most of the time, you stay on one side. There is a right side of the patient and examine. This is the way you examine the right kidney. That is the way you examine the left kidney, by just making your hand, your left hand going behind the loin. Because the sign of kidney is, it is bimanually palpable and ballotable. Ballotable is tossing. That is, you push your hand from behind and you perceive the lump hitting your anterior hand. So this hand perceives when you, like a football, you just push it from behind. So it is ballotable. And also, if you keep both hands like that, ask the patient to take a deep inspiration, and it is palpable, and also it moves with the respiration. Bimanually palpable, and also it moves slightly with the respiration. Okay, these are the three coordinates, and it never crosses the midline. And fourth, of course, is you are able to insinuate the finger between the costal margin and the lump. So these are the cardinal signs of the renal mass. This is one picture for all of you to visualize, photograph, memory. You take it and store it in your temporal lobe. How liver, spleen, kidney, pseudopancreatic cyst. Here is a right iliac fossa mass. Here is a gallbladder mass, like a mucosal gallbladder. This is the bladder, and this is a right iliac fossa mass again. Okay. Coming to the very important sign of any abdominal mass, as far as the undergraduate is concerned, is, out of these 8 masses we described, which one moves easily with respiration? If I ask you, because of the close proximity to the diaphragm, you know, liver mass, spleen mass, and because the gallbladder is attached to the liver, of course, gallbladder, that is mucosal of gallbladder, will move easily freely with respiration. That is a very important. When you say free, at least 2 or 3 centimeters below and above. When they take a big patient deep inspiration, expiration. Okay, so that's the first thing. Which are the masses? They move, but not convincingly. That is, move slightly with respiration. If they ask you, and then you may ask. Very important thing. You may say is a kidney. Of course, you will say, and then some extent, not always, stomach, hepatic and splenic flexure growth in large bowel. Not large bowel as such is not moving, like transverse colon mass, no movement at all. But if they are in the hepatic flexure and splenic flexure tumor, sometimes they can move. And adrenal, because of its attachment to the kidney. But for undergraduate, if you see a renal mass moves with the respiration, that is well and good. All other things, if you know, well and good. No movement at all, of course, the rest of them. That is retroperitoneal mass, pancreatic pseudocyst, aortic aneurysm, or any right iliac fossa, ovarian, pelvic masses, of course, understandably, they are not going to move with the respiration because they are far away from diaphragmatic movement. Okay, that is the most important sign to elicit both by inspection and palpation. Coming to the liver, spleen, right iliac fossa mass, or pelvic mass, whatever it is, they are going to ask you two things. When you see a lesion, they'll say, if you say, I can see abdominally, they'll say, why you say it is a liver, first of all. And if it is, that is anatomical diagnosis. Second, they'll ask you, if you say it is a liver, why the patient has an enlarged liver? Pathological diagnosis. So you should be ready with these two answers. For every case of abdominal mass, you have two answers in your mind. Okay, let us see the first thing. The why you say it is a liver? Because there is a large mass in the right upper quadrant, sir. This patient, I can feel it moves easily freely with the respiration. I feel the lower part about 5 centimeters below the right costal margin. It is dull to percuss, and I can see the upper mater at third intercostal space. It is firm, nodular in consistency, non-tender. Okay, what are the common possible causes? Because you already elicited in this patient a good history, and I already examined the patient. Look for liver failure signs, like any patients, whether the patient is having a spider neve, all those things you put in your mind and come out with the diagnosis. Whether what are the common cause for hepatomegaly? Here is a list. Hepatitis. Okay, usually in exam, a chronic hepatitis, because acute viral hepatitis, acute infective hepatitis, or infective hepatitis like amoebic liver, all those things are never kept. So hepatitis usually means it's a chronic hepatitis. Fatty liver, another condition very often we see in a case nowadays in a obese patient or a diabetic patient. Cirrhosis is very, very common diagnosis. Okay, and cirrhosis always you examine, you expect a shrunken liver, but not always. For example, some causes of liver diseases, especially if they are due to like viral hepatitis B or C, or if it is a case of a Budd-Chiari syndrome, they'll have enlarged liver. So cirrhosis doesn't always mean shrunken liver. Yes, of course, if it is a classical alcoholic liver disease, end-stage liver disease, they will not have a palpable liver, but they'll have a palpable spleen, ascites, dilated vein. Those things will be present. Budd-Chiari syndrome is more common for a large liver. Congestive liver, that is pulsatile liver in a congestive cardiac failure, sometimes tender, pulsatile, soft liver. Common things in exam, very often people come regularly for examination because they are all regular customers to us, is a polycystic liver disease, hydatid cyst of liver. Rarely, if there is a case, they'll keep you like a hepatoma, and secondaries are very commonly kept because they are so common, and usually patient will not have pain, so patient will be used for examination purpose. So usually any primary from gastrointestinal tract like a gastric CA with a secondary liver, colonic cancer, a pancreatic cancer with a secondary liver, breast cancer with the secondaries, lung cancer with the secondaries are very commonly kept. Okay, so secondary liver is another important thing you have to keep in mind because they are large, enlarged, painless, nodular liver. Okay, they have in addition like anorexia, weight loss, or symptoms depending upon the history. You may be able to say this patient has a dysphagia or vomiting. So upper GI pathology. So sir, I think it could be a case of carcinoma, upper GI tract. So I want to do a barium follow through or an endoscopy or a CT upper abdomen. Like that, you can take a case as per the case. Okay, but this is the way to approach. You should know why you say it is a liver and what are the possible common conditions you can think of. Okay, similarly, for a spleen, you can have. Okay, for example, to say this, here is a patient because it is not easily by inspection. On palpation, I felt a large, non-tender, firm mass in the left hypochondrium extending to the umbilical region, going towards the right iliac fossa. I can very easily feel the notch, and I couldn't insinuate my finger between the costal margin and the lump. It is not bimanually palpable or palatable. So I think by all probability, it is a spleen, sir. And this particular patient, I think the diagnosis is a myelofibrosis. Okay, like that you can come to a conclusion, whatever you are going to offer. Because the causes of splenomegaly are here, pathologically. Commonest in our country are these three: portal hypertension, chronic myeloid leukemia, myeloproliferative disorder or myelodysplastic syndrome like myelofibrosis, tropical splenomegaly or a chronic malaria, like blood dyscreasis, hemolytic problems, thalassemia and sickle cell anemia, spherocytosis, things like that. Kala-azar, I think it is only for completion. I yet to see a case of Kala-azar myself. So that's all about the common causes for splenomegaly. Okay. Coming to the renal mass, less common. Take it from me, renal mass are very rarely kept. Now urology is a specialty. General surgeon, they don't keep a renal mass, but it is nice to have that like some hydronephrosis cases, if it is available, or a polycystic liver disease with a polycystic kidney. If they are available, they'll come, because I've seen one patient with a polycystic liver with a large polycyst in the left kidney and kept as a two different mass. So they want to correlate what is this condition like that. Okay, so the mass is in the loin, so they'll have a large mass in the right lumbar region or left lumbar region. It moves slightly with the respiration, and you can ask a patient to go for a knee elbow position to see whether the mass falls forward. That is not, nowadays we don't rely on that, but what you can tell is it is bimanually palpable and palatable, and you are able to insinuate the finger. Okay, these are all the things. And if you want, you can percuss on the loin, okay, below the 12th rib, just lateral to the erector spinae muscle. Usually it will be resonant, whereas it will be dull in a case of a renal mass. Okay, dullness in the loin, corresponding loin, signifies it to be a renal mass. So this is the additional thing you can add in addition to all these things I mentioned. Hydronephrosis, by far the common, but it can be a, like I said, polycystic renal disease, hypernephroma, rarely tuberculosis. Okay, or if they have a congenital absence of a kidney on one side, agenesis, they can have a compensatory hypertrophy of the other kidney. That is quite possible. We have seen that. And also renal mass are peculiar in the sense sometimes you can have unascended kidney. Okay, like kidney or a pelvic kidney presenting as a right iliac fossa mass. So right iliac fossa mass, one of the rare diagnoses, keep in mind. Yeah, kidney, a pelvic kidney. Okay, rare diagnosis, but if it is available, they can keep you. Okay, so coming, that brings you to the right iliac fossa mass. And even in the tuberculosis, Crohn's, we have already said a mass of this description where there is a you can say in the inspection hardly anything to see, and palpation there is a ill-defined non-tender mass in the right iliac fossa of size 4 into 4 centimeter, which is not moving with the respiration. I'm able to see the upper border and also the lateral borders. I am not able to see or feel or reach the lower border. There is no mobility. Okay, and it becomes less prominent on head, neck, and leg raising test. And it is usually impaired resonance or dull to percuss. Sometimes tender to percuss. If it is a tenderness, usually appendicular mass or an abscess. So like that, you can have all the findings, you put them all in that order. Then you give the diagnosis, the handful of diagnosis. Appendicular mass is by far the commonest in our country. Ileocecal tuberculosis. In abroad, you can add Crohn's disease as the next one, but in our country, still a CA cecum or ascending colon, especially in an elderly person, if it is a 50-year-old man. And then ileocecal tuberculosis and a lymphoma. Okay, so this is all the common things. Then there are like amoebic typhlitis, pelvic kidney, iliopsoas abscess, and also the aneurysm of the iliac vessels. There are umpteen number of causes are there, but I think these 5 will do. Appendicular mass, ileocecal tuberculosis, cecal cancer, Crohn's disease. 4 common conditions, if you remember. Well and good. Okay, now we are nearly finished. We will be happy to relieve. We are just in 10 minutes. I know the time. We are going non-stop today, mainly because I didn't want to interrupt before our question, the 5 MCQs. So let us see 2-3 cases beforehand. Here is a patient. This particular patient came to us, a 6-year-old gentleman with anorexia, okay, and also a pain in the upper abdomen, increasing on taking food, with recurrent vomiting, lost nearly 10 kilos of weight, with no significant comorbid illness. He hasn't been taking any particular drug, but he was given lately in the last 2 months on acid suppression drug, like a ranitidine, but with no relief of his pain or symptom. He has no allergy. He has no family history of similar illness. On inspection, he looks emaciated, anemic, Trousier sign present. On clinical examination, inspection, there is a mass in the upper abdomen. Doesn't move with the respiration. Becomes less prominent on head raising test. The skin over the swelling is normal. There is no dilated vein. It is not pulsatile. On palpation, it is not warm, not tender. It is firm in consistency. It moves side to side, slightly, dull to percuss. So like that, if I am giving an exam, then you can tell, okay, examiner, even if you forget, there's any other sign you want to elicit. If it is present, you will look for visible gastric peristalsis. Put a stethoscope to see if it is a gastric mass, whether it is a succussion class is present. So it all boils to a patient with a dyspeptic symptom, elderly person with a significant weight loss, or to be a malignant cyst, gastric cancer. Like that, you can make a diagnosis. Or if it is a lower abdominal mass, this patient has poor stream, nocturia, came with not able to pass urine for the last 48 hours. He had an inspection. He had a distant lower abdomen. Skin over the abdomen is normal. There's no dilated veins, no scar. On percussion, it is a tender. It is not warm. It is tender to percuss. It is dull resonance. Okay. Then on asking the patient to void urine, he couldn't void urine, so we put a catheter. The swelling disappeared. So it is you can very easily say it is a distended bladder. Like that, you can have an idea. Coming to the percussion, because inspection, palpation is so important. But still, if you have a patient where you suspect there is a fluid in the peritoneal cavity, you have to demonstrate, especially if it is very minimal, you are expected, but it is accepted nowadays. Puddle sign need not be elicited. You do not put the patient the hardship of making him knee elbow position. Don't make all this examination. You can always tell, I like to do a puddle, knee elbow test to examine for puddles, but ultrasound is much more sensitive, sir. So that's why you don't, you didn't look for the puddle sign. In a moderate fluid, like more than a liter, less than 2 liters, shifting dullness. Okay, when a patient lies supine, the fluid collects on the loin. So there is a resonant epigastric region. You go to the loin and ask the patient to shift to the opposite side and see the dullness in the loin disappears or it becomes resonant. That's what you see. And the fluid thrill level you elicit, ask the patient himself to keep a hand in the middle like this, and you just tap on one side and you just perceive that tickle on the other side. The fluid thrill is perceived by your other hand. Okay. So these are the things. Can you differentiate clinically an ovarian cyst from ascites? Because both are fluid filled. Ovarian cyst, of course, within a bag of fluid. Here it is a peritoneal cavity with the fluid. Yes, to some extent you will be able to do clinically. This is the way. Like for example, position of the umbilicus. Ascites, not much change. Ovarian cyst, Tanyol sign, because ovarian cyst pushes the umbilicus upwards. And then epigastrium, both it will be resonant. Flanks usually dull in the case of ascites, whereas here the dullness is mainly in this region, in the center, whereas the loins will be resonant as far as the ovarian cysts are concerned. Okay, and aortic pulsation, it is absent. Here, if the cyst, ovarian cyst, is in contact with the aorta, it will be transmitting the pulsation, understandably. Okay, like a pseudo pancreatic cyst for that example. So transmitted pulsation can be seen in ovarian cyst. But what is important? Lab investigation CA125, because it is a cancer antigen 125 is raised in a case of ovarian cyst. That is the keep in mind. And these are all the various positions we examine the patient in various situations. Normally in exam, supine abdomen. Rarely knee elbow position for puddle sign. But there are other signs like knee elbow position. We usually see whether the swelling falls forward, like a renal mass we want to see, or whether the pulsation of mass diminishes. For example, if there's a transmitted pulsation, the transmitted pulsation will diminish or absent on knee elbow position in a pseudopancreatic cyst or ovarian cyst. And rectal examination also can be done in a knee elbow position, but usually we do it in a left lateral position, rectal exam. That is called a SIMS position. Either colonoscopy, proctoscopy, rectal examination, all nowadays done is more comfortable, asking the patient to go with the left lateral this way and you examine with a one leg like this, bend like this. So you have a better access to the anal cavity, and also it is comfortable rather than this is awkward for any patient. Privacy, right? And aesthetic, it is not acceptable for a lady patient like that. Okay. Now, I think good time to stop sharing and start listening to you now. Okay. And let us unmute you all. Let me just see. Rajaram, can you unmute yourself? Are you able to unmute? Melvin, Kadiravan, let me just see the chat box. Anything is in the chat box? No, nothing is there. Yes, Jagan Neti.
Sir, good afternoon, sir.
Yes, Jagan.
Sir, how to palpate liver or spleen in a ascites patient, sir?
Tipping method. I told you, you just do like that. Do like that, you will be able to do. Sometimes in practice, in reality, what we do is we do a paracentesis. After that, we examine the patient again. That is different. But in a patient with a massive ascites or ascites, you do a tipping method, because by tipping, you displace a fluid momentarily where you feel. At that time, you will be able to perceive the. But accurate measurement is not possible in this case. You will have some idea. In a tense ascites, very difficult to see or feel any mass. But in a moderate ascites, it is possible to feel by a tipping method. If you say that, that is good enough.
Thank you, sir.
Any other question? Bharat, Karshini, Priyanka. Let's move on to the questions then. I'm going to ask you, 5 of you, please mentally prepare to volunteer yourself to come out, unmute and answer. Okay? Because this is for you now. Now the time is for you all to give your opinion. I hope you are able to see my first slide. Okay, it is for Gayatri. Okay, Gayatri M. She is going to unmute herself. Your diagnosis. Here, I have a 15-year-old boy came after a month history of trauma, and on clinical examination, he found to have, as you can see, a large epigastric smooth fixed mass with a limited movement with the respiration. Transmitted pulsation of aorta can be perceived or can be seen on inspection, and it is resonant to percuss. Okay, these are all the findings. Can you guess the diagnosis? Anybody for that matter? Don't know whether you are all mute.
Pseudocyst of pancreas.
Melvin, why you say pseudocyst? Very well done. It is one of the important, because the history of trauma in a child with a swelling of that description in this region anatomically it fits in nicely with the pseudocyst of pancreas. Very well done. So this is what the CT scan will show, a large cystic collection. As you can see here, this is, you have to imagine, see all the CT scan as if you are seeing, reading This is the right kidney, for example. So this is the head, body, and tail of the pancreas. There's a large cyst, 10 centimeter cyst of the pancreas. So what is the operation for pseudocyst of pancreas? Melvin, what is the treatment for pseudocyst of pancreas? What is the rule of 6? You want to tell me what is rule of 6? Or anybody wants to say rule of 6? Any cyst more than 6 centimeter, more than 6 weeks old, if they present with another S, that is symptomatic, there is pain, then you ought to do a procedure, either open, laparoscopic, or endoscopically, cystogastrostomy. That is joining the stomach with the, so you drain the fluid to the stomach, because pancreas after all is in the stomach bed. So that is what you should do. Okay. Next, this is another patient. Okay. An elderly patient presenting with a swelling in the epigastric region, which becomes less prominent on head raising test, coronet test sign is present, not moving with the respiration. On putting the hand, it felt pulsatile. So I put the hand like this and it was going like this. Okay. Transmitted pulsation is like that. Expansile pulsation is like that. It is separating my hand. That is the way you have to tell the examiner. If you are not able to be visually, or if you are able to not able to express yourself, at least you have to visualize. So the transmitted pulsation means if I see a lump, the pulse is transmitted like that, to and fro. Whereas here, up and out like that. So this is expansile pulsation. So what is the diagnosis? Anybody?
Sir, aortic aneurysm.
Yes, aortic. Who is that?
Samhita, sir.
Okay, tell me why you tell me what you know about the abdominal aortic aneurysm. 1 or 2 lines. You are absolutely right. Any epigastric mass, elderly person presenting with this finding, you have to suspect aortic. Differential diagnosis, of course, it could be a gastric mass, pseudopancreatic cyst, liver cyst, anything. But the classical finding of this, all this fit in nicely with your diagnosis. Tell 1 or 2 lines about aortic aneurysm. Aortic aneurysm is nothing but an abnormal dilatation of the infrarenal aorta. Very, very important thing. Usually, aneurysm is atheromatous dilatation of the infrarenal segment. So, it is very, very easy to do a tube graft by using a Dacron tube graft. Either surgically, you can do. Nowadays, the whole thing is done with a radiologically, interventional radiologist. They can insert the whole stent, okay, through the femoral artery. That is also possible without even making a cut in the abdominal wall. So either way, you have to replace the diseased abdominal aortic aneurysm by a graft, or else patient has a risk of perforation and also leaking abdominal aortic aneurysm. So patient can die even. Retroperitoneal bleed because of the leaking or ruptured aortic aneurysm. This is a lady, as you can see, a 70-year-old lady presenting with a lower abdominal mass, 10 centimeter, and it becomes less prominent on head raising test, firm in consistency. I can move side to side. I couldn't feel the lower border. Okay. And the flanks are resonant. It is dull to percuss. What is the diagnosis? Here is a RCT or MRI for that matter. This is actually a large ovarian cyst. Okay. Now there is a, whenever you have a diagnosis of ovarian cyst or a solid component like here, or a cystic component where it will be, whole thing will be like a black, like this something like this will appear like in a cyst. CA125 is a tumor marker for ovarian cyst. What is Meek syndrome? Anybody? Any bright answer from you relevant to ovarian cyst?
For ovarian fibroma with ascites and right hydrothorax, sir.
Melvin, well done.
Yes, sir.
So ovarian fibroma is a benign tumor of ovary along with ascites and hydrothorax. So that is what a Meek syndrome is all about. So this is the probably the last slide, I think. What is the sign depicted here? Anybody? There is ecchymosis on the inner upper aspect of the right thigh. You have seen ecchymosis of the umbilicus Cullen sign, ecchymosis of the loin Gray Turner sign, and ecchymosis over the last time also you have seen some other sign. Okay, here is a Fox sign. This is called a Fox sign, a sign of retroperitoneal bleed. Sometimes they can track, the blood can track even below the inguinal ligament over the anteromedial aspect of the thigh like this. Okay, that is Fox sign. And there are two more signs if you're really interested, which are signs of, in other words, if a ruptured abdominal aortic aneurysm or a pancreatitis, there are umpteen number of signs in addition to the Cullen and Gray Turner sign. But at least Fox sign is the one worth remembering, because very often we tend to see this. Rarely you see this two other signs, Bryan sign and Stabler sign. Okay. So that brings us to the end of today's class. And once again, I thank you all for having joined us. The next module, we are making another landmark, that is 20th module. We are nearly 2/3 of our way. And next is also clinically relevant topic I've chosen. How to approach neck swellings, various neck swellings. Because thyroid we have already discussed, like a lymph node mass, like a tuberculous adenoma, Hodgkin's lymphoma, secondary is neck, thyroglossal cyst, branchial cyst, dermoid cyst, all different things we see in the neck. How to approach, how to examine. One of the commonest short case for you. Okay, neck swelling, thyroid swelling, varicose vein, breast lump, hernia, sebaceous cyst, or tumor, skin tumors. These are all common lesions. Repeatedly, you have to examine all those things and memorize all those key findings. So it will become a habit for you. You should not think too much when examiner asks you any questions. So with that note, have a relaxing weekend with your family. See you next week, same time. Thank you. Bye-bye.